over to Facebook to make sure we are broadcasting, and then we'll get it going. And this year we're also broadcasting to YouTube and Twitter or X at the same time. There we go. We are live, folks, and people starting to join the room. So let's not keep you waiting. Let's start the show. Hello, everyone. Welcome to Luncheon with the Experts, a Carcinoid Cancer Foundation and LACNet's program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this episode and every episode, and I'm a filmmaker and a writer, among a few other things, that's been working with CCF for over 10 years to create all kinds of video content. We do documentaries, we do live video series like the one you'll watch today, treatment-based videos, all kinds of videos in that span of 10 to 12 years, but all with one singular mission in mind, and that is to spread awareness and education about neuroendocrine tumors. Now, if you are new to the community or new to this show, I want to say welcome. And I want to encourage you to introduce yourself, as you'll see people doing in the sidebar. Tell us where you are in the world, where you're signing on from. And I would encourage you to reach out and embrace the community. And you'll be pretty impressed at how supportive this community is and how much they embrace you back. The value of this show is twofold, in my opinion. Absolutely, the information and some of the answers that you'll get from our guest today. But secondly, the support, the shared stories, the camaraderie, the community that we've cultivated here as well is extremely beneficial to the journey. So absolutely lean into that. I recommend that. So pardon me. Before we get started, we want to thank our sponsors, Ipsen Biopharmaceuticals. We couldn't do the show without them. And we have this disclaimer from them, and that is that the opinions expressed by the guest presenters, as well as the questions asked by the audience, haven't been created or suggested by the sponsors of Luncheon with the Experts. And CCF does not endorse or promote any of the views and information or opinions provided in the presentation. So, here's the main takeaway. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they may make about their health or treatments. So all of that is to say, each case of this disease is unique. We're going to give you some good answers to your questions and some general advice today, but take that advice back to your home team, which knows your specific case, and make the best plan forward for you. So we are excited to welcome back to the show for a second time, I believe, Dr. Boris Naraev. Dr. Naraev, how are you, my friend?
Good, thank you. How are you?
I'm doing well. Welcome back to the show. For those that may not know you or may not have seen the previous episode, tell us where you work, what you do, and the role that you fill in this neuroendocrine tumor community I alluded to.
Well, thank you for having me. Time flies. It's been 2 years.
Absolutely.
Yes. So I'm a medical oncologist with a subspecialization and passion for neuroendocrine tumors. For many good long years, I was practicing in Phoenix, Arizona. It's good to see many people from Arizona. Hi to everyone. I see many familiar names. I miss all of you. So subsequently, I moved to Florida, and right now, as of October last year, I am at Tampa General Hospital Cancer Institute. We're building a new and great gastrointestinal, neuroendocrine, and endocrine tumors program. So it's quite an adventure. I'm having very good time here in Tampa, but of course I miss all my patients and all my friends in Arizona.
It is a beautiful area that you have found yourself in now. Some of the best sunsets over there on the Gulf. Tampa is quite nice. I'm glad you're enjoying yourself there, and I'm sure you're serving the people quite well. So, folks, go ahead and start sending in your questions. Somebody says, "I love you and miss you, Dr. Naraev."
Thank you.
Hello to everybody who's joining us. Jose from Costa Rica. I love to see how far these programs reach. Inevitably, we'll have people all over the world, which is very exciting. So, folks at home, here's what you want to do. If you know anybody that should be here and maybe forgot about it, go ahead and tag them in the comments or share this video with them. And the best way for you to ask your questions so that you can get them answered is in short little generic bites. So way too much information is really hard for the guests to answer in this format, especially if they don't know your specific case, as I said. And it's also really hard to read as I'm scrubbing through the comments. There is no limit for how many questions you can ask. So ask one, and that leads to the next one. You can continue to ask that. You can ask as many times as you can, but that just helps us field those questions a little bit more. And of course, if you don't get, if you have follow-up questions afterwards, or if you didn't get your question answered, we have the show every 2 weeks, and you can also reach out to us or LACNets at lacnets.org/support line. This support line is for you, for caregivers, for patients, for anybody that is a part of this community that needs support, that needs guidance. That support line is specifically created for you, so you can reach out there. I will start taking in questions, and we have Dr. Naraev for 55 more minutes, so let's get into it. Nancy says, my serotonin level went from 400 to over 600 in 6 months, and my NET specialist was a little bit dismissive of the importance of this test. How do you feel about this test?
Well, as you know, many of you know, serotonin is one of the substances that some neuroendocrine tumors make. And serotonin considered to be responsible for different symptoms that patient might have, like diarrhea, abdominal cramping, wheezing, flushing, etc. There's a long list, as you can imagine. So measuring direct serotonin level in plasma is a good test. In a way, it shows you functional activity of the tumor. So, but the main question is what the tumor itself is doing morphologically. Is it growing or not? If the serotonin level went from 400 to 600, the question is, was it just two measurements? 6 months ago, it was 400. Now we rechecked, and this is 600. Or was it gradually and steadily increasing? As I always tell my patients, one number does not matter. What matters is the trend. So if we truly see a trend that each time you check, it goes up and up and up and up, so it's probably a true increase in serotonin levels. So, however, it does not necessarily mean that disease is progressing. Because as you know, functional tumors could be sitting there for many years without growing, but producing biologically active substances and causing symptoms. So even if this is indeed increase in serotonin level, and this is true, it's trending up. So it does not necessarily mean disease progression. It only probably means the tumor is more functionally active. It does not mean that necessarily cancer is progressing. The only true way to see if the cancer is progressing, and that's the main question, is cancer growing or not, is to do imaging. And usually it's conventional scans, CAT scans and MRIs. I know that many people in the community do PET scans, dotatate and dotatalk PET scans, commonly known as NAT spot, or gallium-68 or copper PET scans. So they're great tests, but for regular follow-up, they're probably not good. So because there is certain threshold when the PET scan could be positive, means it shows cancerous spots as bright. So if spot is bright, it does not necessarily mean the cancer is progressing. So usually PET scans in our practice are used when we cannot get definitive answers from standard of care imaging, conventional imaging, CAT scans or MRIs. But if you do CAT scans, there are no new lesions. And CAT scans are very sensitive. They could pick up things as small as 2 millimeters, which is a little bit less than 1/10 of an inch. So if there is nothing new and the old previously known tumors did not grow or did not grow much, so cancer is probably not progressing. From that standpoint, I would not worry much about serotonin going slightly up. As long as scans look okay, most likely we are okay. So, but it's still worth monitoring serotonin levels because it tells you about the functional status of the tumor. So, but the main question is, should we change the management? Should we change the treatment? The answer is probably no. If this is the only thing that changed, so the serotonin went up a little bit, so probably we would not change the management just based on that.
Got it. Thank you so much. And Nancy did chime back in and say the scans have been clear. So hopefully that question was helpful for her. Appreciate you, Nancy. Next question from Anna. Anna says, can morphine trigger carcinoid syndrome? I don't know that I've heard that question. Thoughts?
That's a great question. So the true answer is we do not know. It's possible. It's possible because symptoms could be triggered by many chemicals, and sometimes you do not even know which ones will. So it's possible. Plus, don't forget, some people might have individual reactions to different drugs, and whether those reactions are necessarily related to cancer or to neuroendocrine tumor, we do not know. But from practical standpoint, if there were instances that something was happening when morphine was used, so obviously a much higher degree of caution should be utilized.
Got it. Thank you. And thanks for your question. This next question is kind of a general question, but I think it's important, especially for newly diagnosed people. Danette, I believe. Do you know if anyone has ever been completely healed of NETs after being diagnosed?
That's a great question. So if neuroendocrine tumors are found earlier in their development, when they're not spread locally or at long distances, so-called metastatic disease, yes, they can be cured. And usually surgery is curative. Surgery is usually curative. Once the disease is spread and went to different places, for example, liver or lungs, so-called stage 4 disease or metastatic disease, cure is not very likely. And generally speaking, in terms of terminology, we cannot say that we can cure a person with stage 4 disease. Probably the best outcome in this situation, when combination of different approaches is used, liver-directed treatment, surgeries, etc., PRRT. So if everything disappeared, we can say, okay, there is no evidence of disease. So this is probably the best we can do for people with stage 4 disease. But early stages, yes, neuroendocrine tumors are absolutely curable.
Thank you so much for clarifying that, Dr. Naraev. And thanks, Danette, for your question. Let me know if we can help you with anything else. Next one comes from Julianne, which is a common one and also a big general question. Once you've passed the 10-year mark of having an endocrine tumor, what would be or what is the general follow-up protocol?
Well, I assume the tumor was removed and we just following up, because usually, as you know, for majority of cancer, the usual rule of thumb is 5 years of follow-up, and 5 years passed, no evidence of disease on scans, you are cured technically and practically. So for neuroendocrine tumors, since lots of them are much slower tumors, we follow people for 10 years so far, and there is some discussion in the expert field whether for some neuroendocrine tumors, the follow-up time should be extended to 15 years, 1-5. So, but if the tumor is removed and we watch for 10 years with scans and physical exams, etc., after 10 years, nobody knows how to proceed. And usually I sit down with patients and talk about personal level of anxiety. So some people, you know how some people, I don't want to know anything about my cancer, just don't call me, I will call you. Okay. Some people are very anxious, and it's understandably so, it's cancer. So some people still would feel very uncomfortable not doing anything after 10 years. And then we could potentially consider maybe annual, means once a year or maybe once every 2 years scans, probably CAT scans of chest, abdomen, and pelvis. Of course, we could potentially have questions from insurance, but usually this is not the case. So the official recommendation after 10 years right now is to just stop monitoring and enjoy your life. Sorry, enjoy your life is not part of the recommendation, but that's the expectation. So otherwise, if people are very anxious and concerned, or if something is bothering, so we would probably feel comfortable continuing with conventional imaging, not PET scans, CAT scans and or MRIs past 10 years, but probably with much lesser frequency.
Got it. Thank you. Appreciate your question. Congrats on the 10-year mark, by the way, Julianne. Folks, if you just joined us or joined us a little bit late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation and LACNETS program. We are here with Dr. Boris Naraev from Tampa General Hospital Cancer Institute. Great questions so far. I want to say hello to everybody. Now we are streaming on Twitter. We're streaming on YouTube as well. So hello to those folks, as well as the majority of our crowd, which still comes from Facebook. We are going to continue with questions from the audience. Next one, this is one I see a lot. So Celeste says, curious, see a lot recently. Curious if you've seen/heard of histotripsy treatment for NET tumors in or on the liver, and what are your thoughts on receiving this treatment? This is a very hot topic, not like necessarily controversial. I just get this question almost every week. Your thoughts, Dr. Naraev?
Yes, indeed. It's a hot topic. We just had long discussion with our Florida neuroendocrine tumor patient support group meeting in January at the University of Miami, when we were there with Dr. Strasberg and Dr. Chauhan and myself and Dr. Haider as well. So yes, it's a new method. It's essentially utilization of ultrasound to destroy tumors in the liver. So it's reasonably new. There is not much data. So as Dr. Strasberg said in January, the threshold for FDA to approve medical device versus approve of a new treatment, for example, medication, the threshold is lower. So the truth is that more data is needed. More data is needed. As far as we understand, it's yet another method of ablating the tumor. So yes, with ultrasound, you could probably address bigger tumors. You could probably address tumors that are closer to the vessels. So whether this is holy grail or not, we do not know yet. Obviously, more research is needed. However, if one finds themselves in the situation when there is a consideration, and it happens quite frequently, it would make sense to talk first to an interventional radiologist at your institution where you are being treated, because usually they can tell whether liver-directed treatment possible, whether it makes sense, and whether histotripsy should be considered. So it's not done, as you can imagine, at every institution. It's a reasonably new method. So it is being rolled out at more institutions and more institutions. So, but it is new. So, but if there is a question about use of this method, I suggest that you talk to your interventional radiologist first, and of course to medical oncologist.
Got it. Thank you, Celeste. Next question from Renee, who I believe is signing on from Germany. So welcome to the show, Renee, if this is your first time. Renee says, I have a PNET diagnosed in 22 with a Ki-67 of 12 to 16%, pancreas and liver. After surgeries, I've been diagnosed again with innumerous METs on my liver. How likely is it that the Ki-67 index goes up? I am on CAPTEM or CAPTEM since October 22 with overall stable disease in the last scans here in January.
Well, this is a complex question. So right. Generally speaking, yes, Ki-67 could go up in the new lesions. As well, there is such a thing like different clones. So it's possible to have different areas of metastatic involvement, let's say different metastases in the liver with different Ki-67. It's not that uncommon. You could have 5% in one, and you could have 15 and 20% in the other. So, but as long as the disease is stable on the imaging with current treatment, this is probably the best possible situation. Of course, without knowing all the details, it's difficult to say more in this situation. But obviously, as long as the disease is controlled, this is great.
Okay, good. Thanks, Renee. Hopefully that helped. Let me know if you have another question. Next one comes from Lisa. Lisa says, if the copper scan showed nothing in the pancreas, but the MRI findings said punctuate T2 hyperintensity, does that mean that there is cancer there?
Good question. Not necessarily. But please understand, remember I mentioned a little bit earlier about some limitations related to the duodenum PET scans, gallium scans, and copper scans. So the threshold is reasonably high. The tumor should be of certain size to be visible on PET scan, to be bright. So the other situation, since we're talking about pancreatic neuroendocrine tumor, as far as I understand, since there is something in the pancreas, minority, roughly 3 to 5% approximately of neuroendocrine tumors will not be avid, will not be bright on duodenum PET scan. So it's possible to have a neuroendocrine tumor that is not bright on copper scan or gallium scan. So that's why negative PET scan, negative means doesn't show anything bright where it shouldn't be bright. It does not necessarily mean the tumor is not there. So, but from the description, difficult to tell what exactly MRI shows. But if there is question about something in the pancreas and they can see it on MRI, but it's not bright on the dotted PET scan and concern persists, so the next most logical step would be either to repeat MRI, probably 2-3 months, to see what's happening to this area, or if there is need to get answers rather soon, one might want to consider endoscopic ultrasound. This is a procedure many of you are familiar with, upper endoscopy, when gastroenterologist goes in through the esophagus and looks at the stomach. So the same method is just, instead of regular endoscope, they use a device which has little ultrasound machine on the tip of it, and that's the easiest way, and not necessarily the easiest, the closest possible way to get to the pancreas as close as possible and take a good look. So if there is something that shouldn't be there, so the endoscopic ultrasound in many cases is helpful in finding it.
Got it. Thank you. Jim says, should patients with grade 1 NETs in the duodenum be seen by an oncologist, or do you think they should only be seen by a gastroenterologist?
Great question. I'm obviously biased, guilty as charged. So, of course, medical oncologist. This is a cancer, period. Cancer means that this is the tumor that is malignant. Malignant means it could spread. If it could spread, it could potentially jeopardize health and potentially life. So yes, so this is real cancer, despite the fact that, as you know, many people in the community still use the term, oh, this is benign neuroendocrine tumor. In reality, there is no such thing, especially if we are talking about neuroendocrine tumors of the duodenum, which is a reasonably rare entity. That they're not as common. You really need some degree of expertise. So help of gastroenterologist is greatly appreciated. And of course, you will need to follow with your gastroenterologist, because in very many cases, regular and more frequent than usual endoscopies are needed. And of course, without your gastroenterologist, nobody can do it. But you do need to see a medical oncologist. This is my opinion.
Got it. Thank you. Thanks, Jim. From Whitney, is there any need for genetic testing for children? I'm assuming children of NET patients.
Oh, this is great and complicated question. So you know that we try to evaluate every patient with a new diagnosis of neuroendocrine tumor. So at least genetic counseling, which means you sit down with the genetic counselor who talks to you about your family history, your own history. They create family tree, and as I tell my patients, if certain things make certain sense to the geneticist, they would proceed with appropriate testing, means actually ordering either blood test or the swab test to see if there are mutations. So the next step would be, if a patient who has cancer found to have a mutation, then the question is, should the children be tested? This is very complex ethical question, because you know, some people say children should not be tested, should wait until they are 18. So it's very complex in every given situation, and it depends on I think it depends on the mutation and the overall situation. I think it would make sense to talk to the geneticist and to talk to a medical oncologist, because it all depends, because questions are what we're going to do with this information, if there's information. But this is usually discussed in those cases when patient who has cancer was diagnosed with inherited genetic mutation. So in this case, I think it would probably be mandatory for the patient themselves to sit down with the geneticist and talk. The geneticists are well trained, and they can guide you in the best way possible how to proceed, how to talk to children, and depending on the age of children, because it's one thing when you have 5-year-old, and other thing when you have 55-year-old, right? So it's different. Adult children obviously could decide and should decide for themselves how to proceed. But when it comes to minors, so this is much more complex and involved situation. And I think your geneticist would be the best source of information in every given case.
Got it. Thank you. Appreciate your question, Whitney. Next question from Sachin. Sachin says, are there other differentials besides NET that cause the same symptoms as carcinoid and show masses in the liver and have elevated 5-HIAA?
This is a great question, differential diagnosis of neuroendocrine tumor. So well, again, it depends on the situation. Usually elevated serotonin levels in blood, statistically probably more commonly related to functional neuroendocrine tumors. Other causes are possible, but when you look at everything separate, let's say high 5-HIA level, okay, that's one thing. Then you have masses in the liver, that could be anything. So, but when you put everything together, the list of possible conditions is getting more and more and more narrow. So that's why we always need a tissue. You probably heard this old expression, tissue is the issue when cancer might be the answer. So that's why eventually we can have several things on the list of differential, but it will all comes down to whether this is cancer or not. And the only proper way to answer this question is to do biopsy, if possible.
Got it. Thank you. Kathy says, is spread to regional lymph nodes and soft tissue of sacrum considered metastasis?
Depending where the primary tumor is. So if to think about it, so by definition, if it's spread to regional lymph nodes, probably this is not. Technically, it's metastasis into the lymph nodes, means lymph nodes are involved by cancer. But if these are regional lymph nodes, means lymph nodes that are sitting next to the organ that is involved by malignancy, so this is not necessarily stage 4 disease. This is probably stage 3 disease since lymph nodes are involved. Sacrum is a little bit different. If there is an area of neuroendocrine tumor in the sacrum, question is, so where is the primary tumor? If the primary tumor is rectal neuroendocrine tumor and it's in the rectum, and this area close to sacrum is probably local regional lymph node, so that's probably not metastatic disease in the stage 4 sense. However, if God forbid a person had or has tumor, let's say in the small bowel or in the stomach or in the lung or in the pancreas, and now it is, even if it's a lymph node next to the sacrum, it's not your local regional lymph node. This is distant disease. So if cancer is in the lymph nodes that are far away from the original tumor, so this is considered to be stage 4 disease. So to answer this question properly, one would need to know where the original tumor is or was.
Got it. Thanks for your question, Kathy, and let me know if you have any other information for us. Robert says, can sandostatin reduce serotonin and 5-HIAA?
Yes.
All right.
Yes, initially, if you, as many of you know, initially somatostatin analogs were used to control symptoms. So, and symptom control was achieved because as well, among other things, production of serotonin was controlled, and it was shown that the levels go down of 5-HIAA, which is a byproduct or product of biodegradation of serotonin in the system. So, and only later it was noticed that in addition to controlling the symptoms, somatostatin analogs actually control disease progression, means they, in many cases, they stop cancer neuroendocrine tumor from growing. So, so yes, it could control serotonin and 5-HIAA.
Got it. Well, thanks, Robert. Hopefully that helped. Next question comes from DA. DA says, have you seen a pancreatic net, a PNET, in the portal vein and in the IVC vein with a large tumor on the head of the pancreas and metastasis to the liver? And if so, and surgery were not an option, how would you treat it, or what would be the options for treatment?
It's not very common. It's not very common for neuroendocrine tumors of the pancreas to involve the vessels in the area, even though location makes sense if it's in the head of the pancreas. As many of you can imagine, it's all there. It's a very tight neighborhood. Head of the pancreas, major vessels, liver, etc. So it's not very common for neuroendocrine tumors to go into the vessels and affect them. It's usually seen in people with adenocarcinoma of the pancreas, the more common cancer of the pancreas. But again, it's possible, and plus there are liver metastases, so things are making sense. The question is what Ki-67 is, because it sounds at least locally aggressive, and obviously it's already in the liver, so distant metastases are present. So if surgical treatment is not an option, and you can tell if surgical treatment is not an option if you had at least 2, maybe 3 opinions from different surgeons. Because remember, it's not your chemotherapy, it's not your systemic treatment. Surgery is very highly and understandably so operator dependent. What is not possible for one surgeon might be possible for different surgeon. It depends on so many different things. So first, of course, you would need to get second opinion, and you would need to probably get a third opinion, and probably those second and third opinions should be obtained from center of excellence, big academic institutions with expertise in treating this type of cancer, surgical expertise. So, and obviously, if you see 2, 3 experts and every surgeon expert tells you, no, we cannot do it, then yes, it's surgically unresectable. So in this case, it all comes down to Ki-67, because the higher the Ki-67 is, the more aggressive you will have to be. So if this is a primary tumor of the pancreas that spreads in the liver, so we have different treatment options. Without knowing the details, difficult to tell, but think about it. First, of course, somatostatin analogs. In many cases, they can control the disease. However, if Ki-67 index is higher, chances are less probably that it will be controlled. Then one can always consider PRRT, peptide receptor radionuclide therapy. This is lutetium. So everolimus. For pancreatic neuroendocrine tumors, one could use sunitinib. So if Ki-67 is high and the tumor is aggressive, means it's growing rapidly, then one could consider chemotherapy. And the most common regimen that is being used in situations like that, especially if you need to shrink rapidly and possibly make it operable, it's to use combination of temozolomide and capecitabine, so-called CAPE-TEM regimen, which is chemotherapy in the oral form, in the form of the pills. So you don't need to do infusion. So there are several treatment options, but of course, it's very individual, depends on so many things: the extent of the disease, Ki-67 index, how healthy the person is, what kind of treatments were done before, and is surgical treatment not possible forever, or the surgeons tell you, if someone could shrink it a little bit, maybe we could remove it. So this is different story. In this case, if you want to be more aggressive, and probably consider chemotherapy. And since the main issue is usually the liver, as many of you know, of course, liver-directed treatments will have to be considered. Of course, there is a caveat when the vessels next to the liver are involved. So sometimes it could be contraindication to liver-directed treatments like chemoembolization or radioembolization. So, but that would be decided by your interventional radiologist. So in a situation like that, everything is on the table.
Got it. Thank you. Thanks for your question, DA. Folks, we are just over halfway done with today's episode. Great questions so far. Great answers as well from our guest. Keep them coming. We're going to keep moving forward. Skip says, hey, Skip, a friend of the foundation, I have heard here and from other experts that nets in the mesentary don't respond well to treatment. What is your opinion on this?
Well, depending on what we're talking about. If this nets in the mesentery, you probably mean neuroendocrine tumors of the small bowel, probably metastatic to the mesentery or to the lymph nodes in the area. Well, it depends what treatment we're talking about. Let's say if we go back to CAPE-TEM regimen, to chemotherapy regimen, yes, now it is known fact that combination of capecitabine and temozolomide is much more effective in people who suffer from PNETs, from pancreatic neuroendocrine tumors. For some unknown biological reason, pancreatic neuroendocrine tumors are responding better to this regimen when you compare to neuroendocrine tumors of the small bowel. So, however, neuroendocrine tumor of the small bowel it's well-known entity, and they can be treated, and they do respond to treatment. So, and treatment options, I was going to say many. There are several treatment options. Obviously, somatostatin analogs are quite effective because small bowel neuroendocrine tumors do express somatostatin receptors that are being targeted by those drugs. PRRT, peptide receptor radionuclide therapy, is effective in controlling disease in the small bowel. So as well, some other treatment modalities, especially if disease is not spread. So yes, it is treatable. It is treatable. So it depends on what treatment modality we're talking about.
Got it. Thank you. Next question comes from YouTube. Don over on YouTube says, what do you do when the octreotide rescue doesn't seem to be working? I can do an injection and I'm assuming half an hour later, maybe, later, I have a flushing episode. So the octreotide rescue doesn't seem to be working.
Great question. Doesn't happen frequently. Well, I can tell you about the probably worst case scenario that I've seen in my practice. It's probably many of you remember, or many of you heard of Dr. Thomas Oderisio, rest in peace, who was a great endocrinologist at the University of Iowa. So we shared the patient who had absolutely horrible carcinoid syndrome. And the patient ended up being, believe it or not, on octreotide drip. So it was sort of a pump like people have for insulin pump, and the person had to be constantly infused octreotide, and it was helping. It was helping. So obviously it was not the first treatment option that was considered, but Dr. Oderisio suggested that, and it was effective. So other thing to consider, unless it was already considered, if rescue is not working, possible consideration of telotrestat. Because as you know, telotrestat is a drug, it's a pill that is approved for carcinoid syndrome diarrhea that is not completely controlled with somatostatin analog. So it's only approved for diarrhea. So however, when you look at the data from the clinical trial, so it was helping people with flushing as well. It just, at the end, when they did the analysis, it did not reach the needed level of statistical significance to be approved for flushing. But from practical experience, when we use telotrestat in real life, we see that it helps many people. We cannot formally prescribe it for flushing only. So, but in many cases, flushing is combined with diarrhea in people with carcinoid syndrome, and telotrestat could be effective in controlling symptoms if rescue is not working. So other potential option would be, unless it was already done, but that's what we would consider if needed, is increasing the dose and the frequency, long-acting somatostatin analog and short-acting. So because it could be, normally it's given every 4 weeks, we could increase the dose, we could increase the frequency to every 2 weeks. The frequency of rescue injections could be increased. The amount of octreotide that is being injected regularly, short-acting, could be increased. So there are ways of trying to fix the situation, because of course quality of life is important, and when you're constantly flushing and or having diarrhea, it's not quality of life. But there are probably ways of dealing with that. Other thing to consider. So usually people have very significant carcinoid syndrome when there is significant disease burden, and usually this disease burden is in the liver. Controlling the disease burden, the cancer in the liver, it was shown to help with symptom control, starting with liver-directed treatments. We mentioned earlier, chemoembolization, radioembolization, blood embolization. When disease in the liver is controlled, those tumors in the liver produce less serotonin and people feel better, quality of life improves. PRRT, peptide receptor radionuclide therapy, was shown to improve quality of life. It is controlling symptoms in many cases. So not just disease progression, but symptom control could be achieved. So as well, people sometimes don't think about it, but surgical treatment. If there is bulky disease in the liver, debulking surgery, removing the bulk of the tumor, might help with symptoms. It's well-known fact. Even if the surgeons cannot remove completely everything, they could think of removal, at least removing part of the bulk of the tumor might help with symptom control.
Got it. Thank you so much. Appreciate your question. Next one comes from Fred. Hey, Fred. Is it possible for a very slow-moving A very slow pulmonary nodule, 9 years, 1.44 centimeters, in the middle lobe with no symptoms. Could it remain stable within the lung and never metastasize?
Do we assume it's a neuroendocrine tumor?
Yes.
We don't know.
Yes, I believe so. Fred's here most of the episode, so yes.
Yes, it is actually possible. Yes, because I can give a classic example. A person has a lung nodule. It's small. Person wants to do nothing about it. People are just doing regular scans, and things are stable for many years, as you mentioned. And then one day you do the scan and you see the tumor starts growing. You do a biopsy. This is neuroendocrine tumor. So probably that's the natural history of the disease. It sits there quietly for quite some time, and eventually it might start growing, and it will need to be addressed. But yes, it is possible for neuroendocrine tumors to sit there quietly. It's not just in the lungs, in other organs, including pancreas. Neuroendocrine tumors could be sitting there quietly for quite some time without growing. Yes, it's possible, and without spreading to other organs, without metastasizing.
Got it. Thank you. And thanks, Fred. Kathy says, what is a Krenning score and what does a score of 3 mean?
Well, Krenning score was used in, I believe that they introduced it in the 1970s. So when daughter-Tate scans were not available, they did not even exist, not that they were not available. So, and we were dealing with octreoscan. So, and octreoscan, the concept is the same. Neuroendocrine tumors exhibit more somatostatin receptors on their surface than the majority of other organs, with certain exceptions, for example, spleen. So, and Krenning score was the way to evaluate the density of those receptors based on imaging. So, there is a formula. You compare how intense the imaging of the area in question is compared to the liver and compared to the spleen. So it's not being used because, as you know, octreo scans are practically not used anymore. If it's still used, then Krenning score plays a role. So there is still attempts to reinvent Krenning score and use it probably for evaluation of daughter-Tate scans. We're not quite there yet. So, but Krenning of 3 means that there is a significant expression of somatostatin receptors on the tumor.
All right, thank you. Hope that helps. Appreciate your question. Lost that question. Kathy, yes. Appreciate your question, Kathy. From YouTube, Rachel says PET scan was earlier in March, and it showed multiple pulmonary nodes, and my thyroid also lit up. So her question is, do I need to worry about cancer in these areas?
Well, first question, if those nodules in the lungs were bright on the scan or not. Because as you know, when you do PET scan, at the same time, non-diagnostic CAT scan is done, and it frequently picks up nodules in the lungs. But whether they're bright or not, that's the whole question. If there are bright nodules in the thyroid, so it's not that uncommon. In these situations, we usually recommend ultrasound of the thyroid to see if there are nodules, if they're looking suspicious, and if anything else needs to be done. So, but obviously, if there are spots, if the thyroid is not looking uniform, so it will have to be addressed, and probably the best way to address it is to do an ultrasound. As for the lungs, it depends if the nodules were bright or not, because as many of you know, lung nodules are very, very common, and majority of them have absolutely nothing to do with any cancer whatsoever. So that's why if it was an accidental pickup on the PET scan, it's one thing, but if they were present before and they're bright on this PET scan, so this is a different story.
Got it. Next question from Mary. Mary says, is there any data on the efficacy of alpha PRRT on peritoneal carcinomatosis?
Two great questions in one. Great. So PRRT with alpha emitters, it's not experimental, it's still new. There are, as many of you know, there are clinical trials. and clinical trials. So probably this is the future because the treatment option that is available, Lutathera is the brand name, so it is beta emitter. So alpha emitters are a little bit different. They might be better. There are a lot of clinical trials ongoing right now. Whether they will be effective against peritoneal disease, so this is a great question because the issue with peritoneal involvement and mesenteric involvement and PRRT is the concern that if there is significant bulk of neuroendocrine tumor in the peritoneum and in the mesentery, and you do PRRT, there is a potential of small bowel obstruction and so-called frozen abdomen when things stop working after PRRT. So whether this is real or not is difficult to tell because we do see it in real life, but how prevalent it is difficult to tell. And obviously there is a concern how to treat patients in situations like that. Right now we're adding steroids in hopes that it will decrease the chance of so-called frozen abdomen. But the hope is that with alpha particles, with alpha emitters, we might have better chance of treating patients with peritoneal involvement without increasing their risk of frozen abdomen and issues related to that. But we are not there yet, but there are a lot of trials, and as far as I understand, preliminary results look promising. Those alpha particles, alpha emitters, are being considered for upfront treatment. For retreatment means people who had PRRT previously and disease subsequently progressed. It's another big challenge. Where are we going from here? So alpha emitters are being researched very, very carefully.
Got it. Thank you. So, Janine says, well, what are some of the treatment options after PRRT? I'm sure there's a lot that goes into that, but maybe we can discuss some of the potential options.
Yes, well, treatment options after PRRT depend on what was done before PRRT. As well, it depends on what kind of cancer we are treating. So, because as you know, treatment options are a little bit different for, let's say, neuroendocrine tumor of the small bowel versus neuroendocrine tumor of the pancreas and neuroendocrine tumor of the lungs. But it all depends. Usually, immediately after PRRT, the big question is whether to continue somatostatin analogs or not, and there is no consensus on that. But in many cases, it's continued. But if there is progression after PRRT, this is a different story. So, and this is what I just mentioned a little bit earlier. This is area of research. But depending on what was done before and where disease is progressing, it's difficult to give one generic answer, but there are treatment options. So retreatment with PRRT means repeat use of PRRT is possible. So there are clinical trials that now looking into the use, as I mentioned earlier, of alpha emitters for patients who progress after PRRT, and more PRRT is being considered. So chemotherapy is an option in more aggressive cases. So as well, use of everolimus, let's say for pancreatic neuroendocrine tumors is possible. Sunitinib is possible. For neuroendocrine tumors of the small bowel, treatment options are a little bit more limited because, as you know, as we mentioned, use of chemotherapy was not shown to be very effective, but we don't have that many clinical trials in that regard. More trials are needed. So it's difficult to answer without knowing all the details. But yes, there is life after PRRT and there are treatment options after PRRT. It's just very individual. That's why one needs to sit down and look at everything that was done, everything that we have now, what disease is doing, where it is liver involved, is liver not involved, so how the overall health is, bone marrow function, etc., and then you can choose. But I can tell you that compared to 10 years ago, we're in a much better spot with many more treatment options, available.
Got it. Thank you. Next question from Huimin. Huimin, let me know if I'm pronouncing that even close to correctly. Huimin. How big positive lymph nodes or tumors should be surgically removed from clavicles or the chest area for recurring thymic atypical carcinoid? Did you follow that?
How big they should be to be removed?
Yes.
That's a good question. If they are involved and the consideration is being given to debulking, means to remove the bulk of the tumor, if we know that the lymph node is involved, it doesn't matter how big it is. If the surgeon can take it out, the surgeon probably should take it out. Because if it's not big now, it will be big later. So, and it could actually complicate surgical removal, especially if there is local growth and local invasion, which might make it unresectable, or surgeons will end up resecting it with what we call positive margins, means something will be left behind in the area. So it's probably, it would not depend on the size of the lymph node, but rather on the fact that it's truly involved and it could be removed.
Okay. And a follow-up question, any immunotherapies available for thymic atypical carcinoid?
As standard of care, no. However, the field is evolving, as you can imagine. Usually what is being done in real life on daily basis in the clinic, patients with metastatic disease, patients with complex cases of non-metastatic disease have a test done called next generation sequencing. So technically it's not patient that is being tested, it's the tumor tissue that is being tested. So this is a test that looks for mutations. And certain mutations would make tumors more sensitive to immunotherapy. And in these cases, immunotherapy would be considered if there is something on the tissue, on the tissue molecular profile that can, for example, PD-L1 expression is significant. It usually a sign the tumor might be sensitive to immunotherapy. Would it be standard of care? Not necessarily, but might it be effective? Yeah, yes, it could be. So as well, there might be some other mutations for which we have targeted medications. So it's not necessarily immunotherapy, but it's targeted medicine. So it could be considered. That's why for all complex cases, we always ask for next generation sequencing on the tumor tissue to help us guide in our choices of treatment.
Got it. Thank you. From Steve, would additional PRRT be advised before new growth if it worked well after the 4 doses? Or should we wait to see if growth occurs?
If it's not broken, there is no need to fix it. So think about it. Usually PRRT is given when disease is progressing. Means you do scan after scan and things are getting bigger or new things popping up. You do PRRT, so disease stops growing. We have response to treatment, stable disease. So for as long as it is stable, so I don't think it makes sense to add more PRRT. There is no data that it will be helpful. Because don't forget, PRRT, it's not an easy walk in the park because there are side effects, there are potential complications. So we might need to use it in the future because don't forget, we look at having neuroendocrine tumor as like having a chronic disease. People live with that for many, many years. And each time I see a new patient, the question is what we will be doing in 20 years, because we do have many treatment options now, but we don't have unlimited treatment options. We don't want to run out of bullets in the middle of the fight. That's why sequencing of the treatments is very important, and timing of the treatments is very important. Is it possible the tumor will eventually progress after PRRT? Yes. Does it mean that PRRT might need to be used in the future? Yes. So that's why we better squeeze the mileage. If the cancer is not growing, what are we trying to fix? So that's why my approach, if it's not broken, there is no need to fix it.
Thanks, Steve. Hopefully that helps. From Elaine. Elaine says, chromogranin A test. I realize it's a biomarker, but what does it really tell us about the tumors? And I'm a 6-year small bowel met to liver thriver. Thanks, Elaine.
Short answer, it tells us nothing, should not be done, period. So I can give a longer answer because it was the thing to do.
Right.
The thing to do. But there is, unfortunately, I wish it was what we wanted it to be. I wish it would correlate for every patient, for every tumor. High chromogranin means disease progression. Lower chromogranin means disease is responding. In some people, this is the case. In many people, it's not the case. It's not very reliable. It's not very reliable. And there was big discussion. And I think in 2018, when we published in 2020, actually, North American Neuroendocrine Tumor Society guidelines, I believe that's when we for the first time said that chromogranin should not be utilized. It's still being utilized. You have no idea how many patients I see for the second opinion whose chromogranin was checked regularly, locally. It went up, and the whole treatment was changed. So medications were changed. People went for PRRT, people had chemotherapy, not because there was progression on scans, but just because chromogranin went up. So it's very controversial topic. So I stopped checking chromogranin many years ago because it only achieves two things. It gives anxiety to the patient and it gives anxiety to the physician. Because think how we treat tumor markers. Let's say colon cancer, CEA, carcinoembryogenic antigen, much higher degree of correlation with tumor progression. But when you follow CEA regularly, let's say it was normal, then it went up. Next step you do a CAT scan. And if CAT scan looks good, you are fine. Yes, CEA went up, but nothing is growing on the scan, you keep monitoring. So with neuroendocrine tumors, that would be the normal approach. If, let's say, chromogranin went up, you do the scan. So if scan looks okay, this is it. Don't worry about chromogranin. But don't forget, for majority of patients, we do scans anyway. We do scans every 3 to 6 months, depending on the situation. So plus there is no good correlation, no good reliable correlation with chromogranin levels. So that's why we usually do not test it, because it does not help us help patients. There is, in all honesty, last meeting when we had in Montreal, North American Neuroendocrine Tumor Society, Dr. Halperin of, there's a big group of people, Dr. Halperin of MD Anderson, he was here, I believe, and Dr. Hab Donaldson, they did present a poster when they're trying to re-examine the role of chromogranin and the place of chromogranin, but the data was not very convincing. There are new and hopefully better tumor markers are being studied. I know Dr. Aman Chauhan of University of Miami is working on it. I don't want to say too much because it's still in the beginning, but there is some promising data that we might have very good biological marker, blood test, hopefully soon. But it should be better than chromogranin.
Got it. Folks, we have time for just maybe one or two more. One I can answer. Beth says, what was the name of the liver treatment that started with histotripsy? Is the new ultrasound procedure that is all the rage right now. Linda, Dr. Naraev, Linda says, is there any concern with being on sandostatin long term? I'm at 106 injections and scans still show tumors in the liver. Are there long-term side effects that we should be concerned about, or a time risk begins to outweigh the benefit? Anything like that?
Well, do not expect that sandostatin will shrink the tumors. It doesn't happen. It controls it. So it's not surprising that tumors are still there, because sandostatin controls the disease, but it does not make the disease disappear. Usually it's reasonably safe drug, because this is analog of a substance that the body naturally makes. So I see patients on injections for many, many years. So from the system standpoint, there are probably no significant issues. Some people might have worsening diarrhea because of suppression of the pancreatic function. So this diarrhea is possible. Probably chances are higher when you are longer on sandostatin. And the other issue that I observed in real life, when people have too many injections, there is scar tissue formation in the areas of injection, and it's becoming physically uncomfortable to get the injections.
Got it. Thank you so much. Marco says, post-PRRT, is a CT better than a PET scan?
Yes.
There you go, Marco.
Because remember, on the CT, you can measure, and you can tell bigger, smaller, or see something new. On the PET scan, it's difficult to measure because picture is fuzzy. If you saw PRRT, picture is fuzzy. PRRT could show new areas of involvement potentially, but for regular follow-up, conventional imaging is probably better. And that's what we do in real life.
Got it. Going to try to get to one more. We have just a minute. Whitney says, what's your opinion on conventional radiation to shrink pelvic tumor impinging on IVC?
If no other options exist, yes, could be considered. Depends on Ki-67. The higher Ki-67, probably the higher is the chance that it will respond to radiation treatment. But it's as you can imagine, it's a very delicate area. So, but it could be considered. It could be considered, especially if vessels are involved. Yes, including proton could be considered. Yes.
Got it. And probably our final one, Marianne says, I just completed the third round of PRRT and granulocytes levels have spiked. Should I be concerned about continuing with round 4?
No, if they went up, that's actually not bad. We would be much more concerned if they go down because of the bone marrow suppression. But usually lymphocytes are affected the longest, then platelets. Granulocytes are not that frequently affected, but usually all the numbers get within normal range right before the next treatment. So no, I don't think it's a reason for concern. Right.
Okay, thank you. And one final one, Samantha says, does Dr. Naraev give second opinions virtually? Do you offer anything like that?
Yes, we do have televisits. Concern is if you are in a state where I'm licensed, otherwise it will be illegal to practice across state lines. So, but yes, televisits are possible, and we do it every day.
All right, there you go, Samantha. One thing before we go, we have a couple of notes. Robin says, another great conversation. Thank you. And by the way, Ashley Chrisman's story is inspiring. That's our latest documentary that is out now. You can find it pinned to the top of our Facebook page. Thousands and thousands of views already. A very inspiring story of a NET patient. And Julie says, really enjoy the way Dr. Naraev answers questions. Good show. And somebody had said, you're very frank, but also very funny. So we all appreciate you being here, Dr. Naraev. Thank you so much for your time.
Thank you.
Absolutely. And we appreciate you, the audiences, being here as well. As always, we hope this program helped answer some of your questions. I'll reiterate, if you have follow-up questions or we didn't get to your question, you can always reach out to us at carcinoid.org or lacnets.org/support line. And you can attend every 2 weeks. We have this show, and we'll try to get to your questions if we can. Thanks, as always, to our presenting sponsor, Ipsen Biopharmaceuticals. We couldn't do the show without them. And finally, my name is Rain Bennett. Thank you for watching. I have been your host. And please join us next time on Luncheon with the Experts. Stay healthy.